I welcome you all for today's webinar on recent update in HCC. With immense pleasure, I would like to invite Dr. Anand V. Kulkarni, Senior Consultant Hepatology and Liver Transplant Center of Hepatology Multi-Organ Transplant at AIG Hospital, Hyderabad. For the welcome and introductory note, the stage is all yours.
Thank you so much. Today we are here to discuss about HCC, liver cell carcinoma. We all know it is the seventh most common cancer in worldwide and also probably in India. It starts at number 10. And we have exciting topics today. We have first talk by, I think the stage will be set by our colleague, Mr. Vishal over here. And what I want to just highlight is today we will be discussing about epidemiology, the clinical presentation of HCC by Dr. Srinivas, followed by surgical management by Dr. Sumana. And then there will be management of locally advanced HCC by Dr. Jignesh, who is a dynamic interventional radiologist in our hospital. Then emerging and neoadjuvant therapy by Dr. Shantan, followed by I will just speak about in general about systemic therapy, the candidates for systemic therapy, available systemic therapies, and then transforming cases treatment for these patients with innovations by Dr. Arif. And lastly, I will just end up with a small case discussion. So may I invite, do we have Dr. Srinivas Reddy here? Srinivas? I'd also like to extend my sincere thanks to AstraZeneca and Isai and my as academic partners for these updates in HCC. Over to Dr. Srinivas Reddy for discussions on epidemiology and clinical presentation of HCC. Has he joined?
Yes, sir, he joined, but he has some network issue. He's joining in 2 minutes.
Acha. But till then, to be basically, we see a lot of HCC patients. Most of our HCC patients we see at a stage when they are not treatable. Today as well, we saw some patients with child B and child C advanced cirrhosis. The treatment options in such situations is very, very limited. So very difficult for us to manage such patients. Usually, if the patient has liver-limited tumors with high bilirubin, we end up doing transplant. But otherwise, these patients, if the patient has good liver function tests, then probably we can select for immunotherapy or any of these systemic therapies. Secondly, recent years I've seen the surge in use of immuno-oncological agents for HCCs. We had the first drug in 2008, which was sorafenib. After that, almost for a decade, we did not have any drugs. Then we got the lenvatinib in 2018, which was published in Lancet Oncology. Dr. Kudo was the first author. Then we had, which gives a very decent survival for these patients, has good choice, especially for these patients, especially in addition to those who undergo local regional therapy, stays and tear. That has been used rampantly by Japanese colleagues for patients who undergo local regional therapy. Next week game, we got this atezolizumab, that is the Iron Brave 150, where this was shown to have excellent efficacy, providing good long-term survival. Then we had the Stride drug being approved, single dose of tremelimumab and multiple dose of durvalumab. The only drug which has shown
Dr.
some long-term
Srinivas
survival
has joined. Yes.
So I'll be discussing this aspect of systemic therapy later on again in my talk. So to that end, to discuss on systemic therapy and other things about HCC in general, from management of surgery to the local regional therapy to systemic therapies to addition of innovative therapies and adjuvant role of these drugs in neoadjuvant therapy, we have our experts today, which we'll be discussing through next 2.5 hours. Dr. Srinivas is a colleague of mine. He is a hepatologist working at Star Hospitals, a senior hepatologist, has extensive expertise in HCCs. And over to you, Srinivas, to discuss on epidemiology and clinical presentation of HCC.
Thank you for giving this opportunity, sir. And I'll share my slides. These slides are visible, sir?
No, sir.
Oh. Can you upload my slides?
Not showing.
Not showing. Vishal, can you upload my slides? Can you run my slides?
I will share.
Hello, Vishal.
Sir, slide show.
Yeah.
Show kar.
Yeah. Can you listen my slide? His voice is coming now, sir?
Yes, sir. It is clear, sir.
Yeah. Okay. So, good evening, everyone. Thank you for giving this opportunity by Dr. Anand, sir. So, today's my discussion is about HCC etiopathogenesis and classification and what are the main genes which are involved in etiopathophysiology. So first thing is the liver cancer or worldwide. The global incidence usually, if you see here, almost 4.8% it is there when compared to the other cancers, and the global mortality also is very high, almost 7.4%. And when compared to present studies, it is the third highest cancer mortality in the world. Next slide. Next slide. Yeah. So if you see here, in 45% of the cases at diagnosis, the liver cancer has spread to lymph node or metastasis, and the prognosis is very poor. So usually at the time of presentation, 44% they have at locally. And if you see 45%, it is usually spread to lymph nodes or any distance metastasis like lungs. And the 5-year relative survival rate, according to the stage, if you see, localized means 33%, and it is spread to regional metastasis, it is very high. Next slide. Next slide. Yeah. So there are the multiple risk factors which increases the development of HCC, and it can vary globally. However, it's most commonly it is now the viral hepatitis infections like hepatitis B and hepatitis C, followed by NAFLD, which is progress towards to NAS related, and there is underlying comorbidities like diabetes and underlying dyslipidemia, and there is some of the studies which was showed even male gender also very high risk for malignancy, and other risk factors like heavy alcohol usage and tobacco usage, and even the geographical variation also can see that there is an increased risk of predominantly in our India. The predominantly more of HCC cases you can see in Arunachal Pradesh and Tripura. Next slide. So there is a globally the HCC is there is a shift in there. Initially, the viral hepatitis B and C are the most common causes, but nowadays the recent publication data which was showed the NAS is more predominant going for HCC rather than hepatitis B and C. So the hepatitis B, which is the most common cause of HCC worldwide, but now it is replaced by NASH, and it is a 5 to 100% fold increased risk of HCC versus unaffected individuals. And there is a strong association between chronic hepatitis B infection and HCC development because of there is a presence of X gene in hepatitis B. Most of the adults which are infected with hepatitis B recover, but 5 to 10% they are unable to clear infection, which are become chronically infected. The reason for development of HCC is two pathways. One is cirrhosis related pathway and second is non-cirrhotic related pathway. The cirrhosis related pathway is mainly because as there is an inflammation is going on in the hepatocyte around this fibroblast, and there is a mesenchymal cells which lead to proliferation and leads to fibrosis. When there is an increased genetic modulation and genetic epigenotypic variations which occurs in this mesenchymal cells, which leads to activation of these activation of tumor forming genes, and along with there is an inactivation of tumor suppressor genes. This is the one of the mechanism, and most of these hepatitis B or C, the mechanism for signaling is the tumor growth beta pathway, which stimulates secretion of tumor growth beta, which leads to increased intercell activation of PNK3 pathway, which leads to formation of tumorigenesis. And the non-cirrhosis related pathway, as we discussed, there is an integration of this viral DNA, mainly X gene, into the host genome, which leads to causing tumor growth. And at the same time, if you see the hepatitis C virus, is the second most common risk factor, and it is a 20 to 30 fold increased risk of HCC versus uninfected individuals. The establishment of chronic HCV infection is mainly, it may take 20 to 30 years. Same like hepatitis B, there is a chronic hepatitis B inflammation, progressive liver fibrosis, and initiation of neoplastic clones, which is present in the organelles like mitochondria, which leads to formation of tumor in hepatitis B related cirrhosis. Next slide. Next slide. Yeah. So as we discussed initially, as hepatitis B, hepatitis C is most common. Now it is shifted by NAFLD. The NASH, which is more common cause for HCC. Why? There is a lot of genetic variations which occurs in NASH related when TNPLA3, which is a genes most commonly involved in NASH, which leads to increased risk of tumorigenesis in these patients. Next. Next. So the reason why in this NASH related, there is a presence of metabolic syndrome and underlying type 2 diabetes, and which is leads to insulin resistance. All these things which is increased to 2.13 fold increased risk of HCC in metabolic syndrome, and type 2 diabetes 4.2 fold increased risk of HCC in underlying type 2 diabetes. And the reason for these things which is more causing for HCC is mainly the insulin resistance. When there is insulin resistance is there, because of this, the organelle, the end organs which will be damaged, and there is increased release of free radicals and increased risk of increased release of free fatty acids, which causing damage to the end organelles and causing cell death and causing the tumor formation. Next. So as we discussed, the HCC is between 2 to 4 times most common cause than males than in females, which is mainly interplayed by interleukin 6 and estrogens. And there is a many environmental factors which is seen in males. This is high prevalence, means commonly persistent hepatitis B infection, alcohol abuse, and smoking. These are the main risk factors why males are more predominant than females. Next. Next. Yeah. So third pathway, fourth cause mainly predominantly alcoholic liver disease. The same like spectrum with alcoholic liver disease like steatosis, then NASH, meta-ALD or ALD, hepatitis, then followed by cirrhosis and HCC. The main pathophysiology in these alcoholic liver diseases is mainly because of increased gut permeability and gut bacterial translocation from this gut, which is activating toll-like receptors 4 in liver cells, which is causing inflammation and causing oxidative and free radical injury to the hepatocytes, and which stimulates this mesenchymal cells in liver disease. Then it is causing tumor formation in long standing after 10 to 12 years. Next. So second is, as we discussed, there is some of the risk factors like smoking or alcohol. Mainly the smoking or what, this is like a carcinogen, which causes liver tumor mainly because of genotypic effects like miscoding events in critical genes and the pro-inflammatory cytokines release like TNF alpha and IL-1, IL-8 and oxidative stress, which is increased reactive oxygen species. All these things can increases the risk of HCC when the patients with underlying etiology like alcohol with HCV and hepatitis B. This is like a co-stimulatory factor for causing liver tumors. Next. So even if you see the HCC, the HCC geographically can be variable. In predominantly the HCC caused by HCV and alcohol is mainly in North America and Europe. The incidence of NASH is projected to be increased by up to 56% in next 10 years, which could be increase the incidence of HCC as we discussed previously. And if you see here, HCV caused by hepatitis B, predominantly in Africa and East Asia, 60% of these causes are hepatitis B related when compared to Western world. Next. So, as we discussed the etiology, hepatitis B, hepatitis C, and substance abuse like alcohol, tobacco, and some aflatoxin like some of the toxins which can cause liver cirrhosis, like metabolic causes like NAFLD and others like risk factors like male sex and geographical variations and some of the autoimmune causes. All these things can increases the risk of inflammation, and this inflammation can cause cirrhosis and then HCC. If you discuss very detailed in detail, the hepatitis B, it is the most the genes, the main pathophysiology which was involved here is which is involved the some of the genes which were in the TCB of signaling pathway. In hepatitis C, there is a pathway is called as STAT3 pathway, which is stimulates these mesenchymal cells and causing liver HCC. Yes, next. Next. So as we discussed, this is the paper in 2023, which was published by Prabhakar T et al., which was showed instantly hepatitis C is the predominantly cause for HCC fracture. Now it is replaced by NAFLD, then followed by hepatitis B and hepatitis C. So very important is that we need to keep our lifestyle styles with very tight to reduce the increased risk of HCC. As my professor told, there is any 1 kg increased by your weight, there is a 17% of risk of HCC in these patients of NAFLD. Next. So I think these BCLC stages, next speaker will speak about BCLC staging, all these things, and what are the treatment options can be given. And next couple of speakers will speak about all these things. Next. So this is updated BCLCC in 2022, where in stage in advanced stage 3, the systemic therapy which when held to treat the hepatitis C, usually it is showed that some of the studies even showed 20 to 30%. There is showed there is a complete cure rate with these immunotherapy drugs. First line is atezolizumab plus bevacizumab or durvalumab plus tremelimumab. Next. So when we discussed about HCC, the optimal treatment should be discussed. It is a multidisciplinary team to discuss with HBB surgeon and hepatologist and oncologist and pathologist and along with that interventional radiologist. Which stage is there? Which stage? How to categorize whether it is A, B, C, D, and how to treat, whether to give local regional therapy or systemic therapy. What are the etiology underlying this? This all to be discussed, and we need to give possible cure the patient predominantly by giving loco-regional or systemic therapy, or even we can even think option of giving liver transplant also. Next. 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 Yeah. So thank you so much for giving this opportunity. So as by this main discussion, we need to think about the most common etiology is now NAFLD or NASH, followed by hepatitis B and followed by hepatitis C. So we need to be keep our lifestyle healthy and to need to tell every patient in OPD to keep your weight in should be controlled. It will progress towards HCC. Thank you, sir.
Oh, thank you, sir. For the next talk, I would like to invite Dr. B. Jignesh Reddy for the next talk.
Vishal,
Yes, sir.
can you put my slides on? Hi, this is Dr. Jignesh Reddy, consultant intervention radiologist in AIG Hospital. So, being in such a big institute, we are lucky enough to see a lot of significant spectrum of HCC cases and gain experience and knowledge about the disease itself. So, without wasting time, I would like to quickly go into the get full screen. No? Can I get remote access? Are the slides visible? I don't have the slides on screen.
Slides not visible. You are visible.
Yeah, it was there and last Vishal.
అది మీరే షేర్ చేసేయండి రావట్లేదా
Sir, sharing.
Okay. So we've started with epidemiology. Now I think we're directly jumping into management. So the role of intervention radiology among all the cancers, the major role or probably most significant role is in hepatocellular carcinoma. So right from diagnosing imaging wise or tissue diagnosis to treatment management, IR actually plays a significant role, as you know, in HCC management. So in our daily practice, we see significant chunk of HCC cases, right from carcinoma in situ like a LR3 nodule to a very advanced stage disease. Yeah. Is the screen visible for everyone?
Yes.
Yeah. Go to the slide. No. Come on. Change the slide. Yellow. Yes. Second. Next one. So the available loco-regional therapies can be grossly divided into two major techniques. One is ablative therapies and the other is vascular therapies. In ablative therapies, it started with initially with alcohol infusion, which is not performed nowadays, but then to thermal ablations like RFA, microwave. From thermal ablations, we have gone into cold ablations like cryoablation, and now more advanced is IRE, where it's non-thermal, non-damaging modality. And the other vascular interventions, as you know, is TACE and TARE. And we usually in our practice are combining these therapies. Even LRTs we are combining for patient benefit and increasing survival. Next. Let's get to the next slide. So, as all of us know, in the latest BCLC guidelines, the importance to IR therapies has actually increased, where the options for ablation and TACE have increased, and not more specifically, it is the introduction of TARE into BCLC. This is after a landmark trial from US, where they showed a significant overall survival benefit in single lesions. Radioembolization has been added into the BCLC system, and also TACE as the modality in BCLC O and 0 and A patients, which the typical therapies are not feasible. Next. Coming to ablation, now the importance of ablation can be broadly into two categories, can be seen in BCLC 0 and BCLC A, where there's a huge studies and literature where the ablation therapy is equal to surgery in HCCs less than 2 centimeters. So that is something that is well established right now, and for any HCC which is less than 2 centimeters, probably we are doing more of ablation rather than any other therapy right now. For lesions 2 to 3 centimeters, the literature is increasingly coming where RFA or microwave, whichever the ablation therapy it is as good as surgical resection with similar overall survival and lesser complication, lesser hospital stay, lesser financial burden to the patient. Next. And this paper which is on the screen, which is from JVIR, proved a histological evidence of validation where RF ablation is as effective as resection. Following these were the cases where ablation was done and taken to resection and saw complete tumor necrosis. Next. These papers have proved that the RFA is equal to resection. The survival benefit and the tumor response, the recurrence rates were all similar to resection, and now globally and especially in our AIG practice, any lesion which is less than 3 centimeters, ablation is the first choice to go in CLD with portal hypertension. Next. I would just try to explain the difference between the RFA and microwave, because a lot of physicians even today ask, why are you doing an RFA instead of microwave? What is the difference? The difference is in the technology. So microwave has faster ablation times, lesser complication, more wider ablation zones. So the and also risks to the patient, complication to the patient are also less. And because of all these factors, now the intervention radiology practice has moved more towards the microwave compared to RFA. Yes, microwave is a little more expensive, but the intervention radiologist find microwave as a friendlier therapy option. And even the studies have proven that for lesions which are under 2 centimeters, both are same. Probably for the lesions more than 2 centimeters, up to 4. 3 is usually the cutoff, but up to 4, and some institutes and some countries are doing microwave alone. Next. So I would like to show some cases in between these LRT, these things which have been done in AIG. So this, if you see a segment 8 HCC, which is to just 2 centimeters, and you see some ascites. Now ascites is not a contraindication for us to do ablation. And if the criteria of PCLC is in the patient performance is good, so we go ahead and do an ablation without any significant risk of bleeding. So post ablation, you can see a complete necrosis on the 4th image, but there is no arterial enhancement. In the pre-treatment, you can see a nice arterial enhancing lesion, a round lesion in segment 8. In the post ablation, you see a nice necrotic cavity and without any peripheral enhancement. So this is a microwave therapy, and we commonly see such nice ablation zones with margins post microwave, and our microwave success rates are also very significantly good. Next. So this is another lesion which I just wanted to show how we were doing, and this we captured the images during the treatment. So you can see a lesion in the segment 5. Pre-ablation, it was more of isoechoic, but because of the capsule, we could differentiate with the parenchyma. The needle was there, and we started ablating. If during ablation we see that white thing is actually burning and air that forms because it's secondary to the heat. At the end of the ablation, post ablation, you can see a nice necrosis and peripheral edema. This peripheral edema should not be confused with residual lesion. Whenever we are imaging in the first month, especially in CT, we see this peripheral edema, and you do an MR, the edema will be less, and you do another scan after a month or so, you will not see such a peripheral edema. And the important thing here is to not confuse it with residual lesion, and that is complete response. Next. I just wanted to show about this particular procedure. It's an interesting development, cryoablation. So the difference is that here we are freezing the lesion instead of heating the lesion. So the all the microablation are done under either conscious sedation or general anesthesia. This does not require anesthesia also. We just do under local, because by heating, the nerve endings are also numbed, and this is a painless procedure, relatively painless procedure, and also can be used in locations which are otherwise contraindicated for ablation, like near the gallbladder or colon. So we can, even those not to go areas of the liver lesions can be easily treated with cryoablation, and this is picking up now even in India. Next. Coming to TACE, the transarterial chemoembolizations, there are two ways which we intervention radiologists do TACE. One is a conventional TACE where we use lipidol. The other one is by using particles, that is DEP TACE. So now in global practice, usually it is the West does DEP TACE and East does conventional TACE, and we have shifted to completely into the conventional TACE with very good results. So what is the aim of doing a TACE? We do TACE either for palliation, which is mostly in the intermediate stage and which is more common than anything else. Then and the other two is bridging to liver transplant when the patient is waiting for liver transplant, or downstaging to transplant if the AFP is higher than 1000, or if the lesions are very big and we want to downstage them to the institute driven criteria for transplant. And probably our load of palliation is 80%, and the rest 20% only will be downstaging and bridging. Next. So this meta-analysis proves that so this is very important to counsel the patient also. The objective response, that is partial and complete response, is nearly 52%. But I would probably say that in our institute, it would be much more in our selected patients with a good survival of 20 months, and overall survival in the first year is around 70% in this systemic review. Next. So this is one interesting case. It's having two lesions, two large, very arterially enhancing lesions with a significant artery seen in the imaging, as you can see on the screen. We have done lipidol test, and you can see in the bottom two images that the lipidol is radio opaque. So the density of lipidol uptake, you see, completely has filled nicely and dense packing. And whenever you see such an image and the patient goes to resection also, a complete necrosis will be seen in most, and that is proven in studies too. Such a good lipidol uptake is seen in the lesion. And that the fifth image would be the image post TACE. We have done a repeat imaging for 1 month follow-up and showed complete necrosis of the lesion. So even a complete necrosis is achievable with a good TACE in a hypervascular tumor, even in larger size, larger than 3 centimeters. Next. Coming to combination therapy, I was more interested to show this because for lesions, our practice nowadays is for lesions between 3 to 5 centimeters. We are straightforwardly going to combination therapy. So we combine TACE plus microwave ablation. We do TACE first and microwave later. And there now significant literature is also coming up where combination therapy, some are going in Chinese are going even above 5 centimeters. They are doing combining two treatment options, and our responses for combination therapy is now very good. And so when you combine TACE, which actually reduces the blood flow in the tumor microvasculature, which augments the ablation treat therapy. So the ablation zone will be more. We need little ablation. A faster ablation is possible, safer ablation is possible, and more effective ablation is possible post TACE. Next. So this is similar study where it has proven, it is comparing TACE with non-TACE and significant survival benefit in having in ablation in the combination therapy. Next. With comparative complication rate. Next. So this is a case where we have done a combination therapy. It's a segment 7 lesion, diffusion restriction. You can see the first image. Second image, faint arterial enhancement, and the third image, we have a typical washout. So it was 3.8 centimeters coming into our criteria of combination therapy, that is 3 to 5 centimeters. Next. So we have done TACE. If you can see, we have gone from the femoral root. You can see the smaller wire kind of structure is actually the microcatheter. It's a 2 French microcatheter, less than 1 mm. And you can see the number of loops that happen. This is how selectively we go near the tumor bed and then give the lipidol. You can see those dots. That is the injection, the shot taken during the injection. This micro droplets of lipidol going inside. And the third image is the last image of after the TACE, where the lesion is nicely taken. The lipidol is being nicely taken. And we have done, we usually do ablation after a day or two. Next. And compared to the pre and post images, the second one is the second series of images are the post ablation image, post follow-up image after 1 month. You can see a complete response even for a lesion which is 3.8 centimeters. A complete response noted post combination therapy. Next. So similarly, I wanted to show this one because there were two lesions in two different lobes. Yet we went ahead to do a combination therapy in this case. Because of the arterial hypervascularity, the images were from an outside hospital, and we selectively went very close to the tumor, gave the lipidol in the tumor bed. Next. And ablated both. And you can see the follow-up MRI where both the lesions show complete response with a significant reduction in AFP. Next. I would now coming to TARE. TARE was initially started as a therapy for advanced HCC, now being done even for BCLC AA HCCs. So regarding radioembolization, the name is actually a misnomer. It is not a radioembolization per se. It is now being called in the radiology circles as radiotherapy, where we are it's being called as an SRT, where it's not, we are not, the aim is not tumor, rather give a intervention radiotherapy intravascular. Next. The initial SARA trial that was comparing the Y90 therapy with sorafenib gave mixed results, were not so positive results for the intervention radiologist. That the backdrop was actually the way the infusion happened. Because the procedure was new, not many people were very keen on how exactly to do that. Now recently the procedure has been streamlined so well, and the intervention radiologists have gained so much expertise in Y90 therapy that the results are becoming now better. We are going and doing it very selectively rather than being very as an infusion therapy. Now we are doing it ultra selectively, focusing on the entire lesion surface. Multiple feeder vessels are being targeted. Use of cone beam CT as also helps in a better Y90 therapy results. Next. So this is that landmark trial which led to the introduction of TARE into the BCLC. This was done for early HCCs and also an advanced HCC. Single lesions were selected, where significant, very good overall survival and objective response was noted. So, but the only problem in India with this, to just follow legacy trial, this thing is the cost. So it is the cost for TARE is around 30 lakhs in most of the centers in the country. If the patient is affordable, yes, we are doing TARE. And the TARE versus TACE, comparatively, TARE has better response rates, better time to progression rates, and better overall survival rates. That has been proven elsewhere also. Next. So many institutes now are using TARE over TACE for bridging to transplant, to get the patient to transplant, and even in AIG we have done TARE first and then transplant, downstage to transplant or resection in quite a few cases, and the explant showed complete necrosis in significant number of them. So I think as the insurances are increasing and the patient's affordability increasing, TARE is a very nice option for such patient population. Next. So this was one study where, because many of the physicians refer us, why are you doing TARE over TACE? Now, this particular study is the comparison between TARE and DIP-TACE, where the study was intermittently closed because of the significant difference between TARE versus TACE in the overall survival. So interimly it was closed because the study was achieved. The primary responses was achieved. Next. Yeah, I would like. So we have done a lot of TARE, but I didn't want to show the straightforward ones. I wanted to show actually a difficult lesion to be treated. So usually infiltrative lesions, as you know, are very difficult to treat by intravascular therapies, even TACE or even TARE. So we went ahead to do this infiltrative HCC in the right lobe with the tumor thrombus that you can see on the right side image, the center. That's a tumor thrombus in the right portal vein. So we went ahead and did ultra selective TARE with multi-feeder therapy. Next. So you can see the first bright images are actually the PET images post Y90 deliver on the same day, and the bottom images are the images in the follow-up done after 3 months. You can see the portal vein tumor thrombus has been reduced into a bland thrombus now, and also the tumor enhancement has gone. And this patient actually went on to get liver transplant and now is still alive, disease free. Next. Next. So coming back to the same thing, that tear has a better response rates and survival rates over TACE. Yes, the down part is that the therapy is expensive. Next. And during counseling, so the contraindications for TACE, I would say first, are actually our tear would be the involvement, the extent of the involvement of the liver more than 50%. Usually, we do not treat it both in both therapies. And for tear specifically, is that the lung shunt fraction is what we check in the first part, and where the if it is more than 30 gray, we are usually not going ahead and doing tear. Regarding portal vein tumor thrombus, we go up till the main portal vein. Only if the confluence is not involved, we are not doing tear. Otherwise, the spectrum of indications has been widely increasing. Next. So, how do you choose LRT? It should be a tailored approach for each case. Yes, we do speak to the physicians, we attend board meets, we discuss, we gain knowledge, we explain them about the new techniques, how we are doing those therapies, and even to the patients, we prognosticate prior to the therapy. Team approach is very important in HCC management, even when you're doing LRTs. Thank you.
Jignesh, can I ask a question?
Yeah, please.
What is the difference between SBRT and TARE? Where do you mention SBRT and TARE?
Okay, so SBRT is stereotactic body radiotherapy, that is an external beam radiotherapy given onto a focused point. And TARE is intravascular delivery of radiotherapy emitting particles, microparticles. So we are going into the tumor feeders and giving this millions of particles into the lesion, and that is an external beam that is focused onto a tumor. Now the difference is, where do you do SBRT? Now the literature says below 3 to 5 centimeters is for the lesion or the lesion microenvironment. SBRT works well. Tear has no limit on the size. As small as 3 centimeters, as large as 15 centimeters can be done. In tumors with portal vein tumor thrombosis, so what we do is, if the portal vein tumor thrombosis is extensive, that is involving VP4 or VP32, where tear particles might not enter into the small portal vein tumor thrombus feeding periportal vessels, we focus the SBRT onto the portal vein tumor thrombus and do tear for the lesion per se. So combining both, we seen getting good results. That is the difference, and also the synergistic effect.
Now, the legacy trial which you showed.
Now that is only tear.
That is only 10. No. The size included there was, I think, less than 8 centimeters or less than 5 centimeters.
Yes. Legacy trial, the size was less than 8 centimeters. Single lesion. Child A. They had few cases of child C also, but child A. So that trial, and because of the trial, the drug got FDA approved for HCC and also included in BCLC. But the trial was not for portal vein tumor thrombus per se.
I think where do you tear this better? Because radiologist kept a message to me saying, that it's also been part of this. We have more role than IR.
No, I think that turf war always will be there between ablation, resection, SBRT, tear. Yes, SBRT is cheaper, true. But again, size, microenvironment, location of the lesion, the bilirubin, where the lesion is, how much can they focus, how good the people are to how good they are in doing SBRT. I think all that also should be taken into criteria rather than just the size.
Thank you so much, Jignesh. Thank you so much.
Thank you, sir.
For the next talk, I would like to invite Dr. Arif Khan.
So I will be loading the slides or I will share the slides. Shall I share the slides? So we shall start about. Okay, good evening, everyone. Thank you for the opportunity, AstraZeneca and Dr. Anand for this opportunity. From local regional therapies, we will be switching to the systemic therapy options. Obviously, systemic therapy is indicated in mainly in the advanced HCCs, unresectable HCCs, which are outside the scope of local regional therapies. I can't move. Yeah. So coming to the incidence first, the globally liver cancer is the 7th most common cancer and 4th most frequent cause of cancer-related mortality. When we dissect the Globocon data, we can see here the liver stands at 4th in the mortality, and the liver cancer is the 7th most common cancer. The first is lung, breast, and colorectal cancers, followed by liver. Next slide. Among the liver cancer cases, 45% of cases are diagnosis are usually in the locally advanced stage. We can see here the 44% of cases here are in the advanced stage, locally advanced stage. And when we come to the 5-year relative survival, localized has obviously got a good survival, 5-year survival, around 30%. And the distant meds is where the prognosis is very, very dismal, or only 2.4% patients have 5-year survival in the distant advanced stage. Next slide. In India, as compared to the world data, it's 11th most common cancer, and it's the 8th most common cancer-related deaths in India. And among the men, it is almost the 2nd most common cause of cancer-related mortality. It is predominantly seen in males. The median age is around 40 to 70 years. And the frequency, we know that the cancer, any cancer, it increases with age. And the incidence is more in cirrhotics, as we know that cirrhosis is the most major risk factor for the development of HCCs. Among the HCCs, when we classify according to the BCLC's staging, the classification, predominantly it's in the stage B. Majority of them present in stage B, followed by stage C, and followed by stage B, and A is the only constitutes only the minority of the stages at the presentation. Next slide. Next slide, please. So how does the HCC develop? So it starts in the tumor microenvironment. It develops because of, first we need a etiology for it. So in case of HCC, it's either via viral infection or the NASH related hepatic damage or alcohol abuse, it is decreasing nowadays. The major etiology what we see is the viral hepatitis or the NASH related HCCs. These etiological risk factors damage the liver parenchyma, leading to cell death, and this cell death actually leads to the immune dysregulation. So the more and more of immune cells come into the liver, and the pro-tumor inflammatory carcinogens lead to the development of the tumor. That's how it progresses through various stages. And in the immune escape and the immune dysregulation happens at the level of the tumor microenvironment. There is overexpression of CTLA4 and PDL1. So we have got drugs to inhibit this, the molecules at the molecular level. And that's how we are going to treat these SCCs. And we are going to discuss about this in the coming slides. So next slide. So as in the previous slide, the viral agents, HBV and HCV are most common for alcohol, again, fatty liver, and these all culminate in causing a chronic inflammation leading to cirrhosis. And the cirrhosis, again, acts as a major breeding ground for the development of HCCs. Next slide. This is one Indian study where they looked at what may be the major risk factor for the development of cirrhosis. It was a multicentric study conducted in India, published in 2023. But that the most common etiology in India for HCC is fatty liver, not the viral hepatitis. It constitutes around the 35% of cases are attributable to non-alcoholic fatty liver disease, followed by viral hepatitis B and C. And alcohol comes as the last risk factor for the development of HCCs nowadays. Next slide. We'll move on to the development, basically the management, how we manage the unresectable SCCs, those who have become quite advanced, those who have gone outside the liver, the nodes, and also which has developed the metastasis. This is the BCLC algorithm. Again, we have seen it multiple times. I'm going to discuss the management of BCLC-C and BCLC-D. So BCLC-C is basically managed by the systemic therapy now. So the major, actually the difference between the earlier BCLC algorithms and now it is, if you downstage, we can move on to the loco-regional therapies. So basically the main treatment for the BCLC-C patients is systemic therapy. Among them, we have a lot of options now. We have got IO options, IO VEGF options, and IO TKI options. So we are going to discuss about it. And the second line, we have got mainly TKIs and also other agents. We are going to discuss about this. So next slide. This is how the treatment evolved. Started with sorafenib. Mainly sorafenib was the mainstay of treatment for a long time. Then came the lenvatinib. It was proven in the non-inferiority trial that it is non-inferior to sorafenib. Then came nivolumab as the single agent that did not work. And later on, the game changer was atezobev. Atezobev, now we have got durva-tremi. It is an excellent option in the advanced SCCs. We are going to discuss about the trial, Himalaya trial in detail in the coming slides. Nivo-EP has also emerged now. It's an option now. It has been FDA approved. So we have got 3 systemic therapy options in the first line now. Atezobev, we have got a major experience with this combination. It has worked fantastically well. We have got durva-tremi, which is proving to be equally well. Next, we have got the Nivo EP in this arena now. So we have got 3 systemic therapy options which are equally good and work equally well, improving the survival and the outcomes. The Nivo is again the newest option which we have got. Next slide. The earlier trial, SHARP trial against sorafenib versus placebo, it improved the survival by 3 months. PFS was almost similar in both the arms when compared to placebo. Sorafenib is a difficult drug to handle for the patients. They have got a lot of side effects, HFS, diarrhea. Most of them do not tolerate the standard dose. We had to reduce the dose. And it also, it's most of them, the survival which is improved is very marginal. So survival improvement is very marginal. Then there came the reflect trial, the lenvatinib compared to the sorafenib as a non-inferiority trial. Again, it has proven non-inferior to sorafenib. PFS was improved, OS was almost similar. This is also a good drug, but only has got side effects when we use in the standard doses. And then came the other agents, which we are going to discuss about that. So next slide. This is the game changer, actually, the immune checkpoint inhibitor with anti-HF, atezo-bev. Next slide. Coming to this, I will not be going to much of the details. So the study design phase 3, we know that locally advanced metastatic or unresectable HCCs who have not received any prior systemic therapy, they were stratified according to region, COG, macrovascular invasion or extrahepatic spread, and also according to the AFP levels less than 400 or more than 400, 2:1 randomization, atezo-bev versus sorafenib. 500 odd patients. The treatment was continued till the loss of clinical benefit or toxicity. And this primary endpoints was overall survival. Key endpoints, secondary endpoints were response rates, and the PFS is also a co-primary endpoint. Next slide. So looking at the curves here, the overall survival significantly improved. We can see a good gap in the curves here. At all the time intervals, we see the improvement in the survival. At 6 months, at 12 months, at 18 months. So we know the median OS is 19 months as compared to 13 with sorafenib. Good hazard ratio 0.6, significant p-value. And the progression-free survival is also significantly improved at all time points. 6 months, 12 months, or 18 months, median PFS 6.9 versus 4.3, hazard ratio 0.6, quite significant, and significant p-value. Next slide. Subgroup analysis, all subgroups benefited by except the non-viral HCC. Here we can see this hazard ratio is not so good. 0.91 and crossing the unity. So it may not work so well in non-viral HCC, that is NASH related. We know that in India, many of the studies have shown that the major risk factor for development of HCC is non-alcoholic fatty liver disease, and may not work in those cases. It works very well in the viral hepatitis induced HCCs. And it also worked in other risk factors or other subgroups, even in the extrahepatic spread or macrovascular invasion, it worked very well. So next slide. Toxicities, we know that atezo-bev, basically the toxicities are attributable to the bev component like hypertension and proteinuria. It is the predominant side effect which we see. The others, but they are far less than the sorafenib. When we compare here, the diarrhea is more in sorafenib, the HFS is more in sorafenib, and hypertension, we can see it's almost similar, but more in the atezo-bev arm. And proteinuria, we can see here, because of the bevacizumab is more as compared to sorafenib. Next slide. This will be the talk of a study of this. I will be talking much about this study, the IO-IO combination. This has again proven equally challenging to the atezo-bev and has improved the overall survival and also the other endpoints, which we are going to discuss. Next slide. Why should we combine this immune checkpoint inhibitors? In atezo-bev, we combined IO with VEGF. We will be combining IO-IO. What is the basically the mechanism or the rationale behind it? So anti-CTLA-4, the tremelimumab, actually it acts on the lymphoid compartment to increase the number of T reactor cells. What it does, it purges the T cells outside the lymph nodes into the tumor microenvironment. The T cells it acts as a single priming dose of which increases the burst of T cells into the tumor microenvironment. So one dose, the STRIDE regimen includes only one dose of tremelimumab. It acts as a priming factor. The increases the burst of T cells from the lymph nodes into the tumor microenvironment. Then once the T cells reach the tumor area, it is activated. The T cells are activated by the PD-L1 inhibitor, that is a durvalumab. So this is the rationale for combination of these two drugs, which enhances the synergism between these two drugs and enhances the anti-tumor activity. Next slide. Again, we're showing the mechanism of the synergism here. The CTLA-4, the molecule actually is a regulator of T cell activation in the lymph nodes following the antigen presentation. Tremelimumab blocks the CTLA-4, allowing the T cell activation and the burst of the T cells from the lymph nodes in the tumor microenvironment. The PD-L1, once the T cells reach the tumor area, it is activated. The PD-L1 is blocked and it activates the T cells, mainly the cytotoxic T cells, which are very effective in killing the tumor cells. So that's how the durvalumab acts, and these two drugs act in a synergy, thereby improving the outcomes in this dreadful disease. Next slide. Again, the pre-lab experiments which had showed the preclinical experiments that when we give a single priming dose of tremelimumab, what it causes, it acts as an increase in the CD4 cells. So the dosage was mentioned as 300 mg single dose. It was studied in the lab experiments that the nivo-IP single dose actually causes a proliferative burst of T cells, which is not, when we repeat this dose, it doesn't happen repeatedly. Only single dose is enough to cause the initial burst of peripheral T cells. Thus how this works here. This single dose of tremelimumab with the durvalumab has excellent activity in causing initial burst, and these T cells are activated by the durvalumab, causing the effective tumor cell kill. Next slide. First, it was this regimen combination was studied in a phase 2 study here. They tried to find out what is the appropriate dose. Initially, these two doses were studied, the 75 in 4 doses and 300 single dose, the STRIDE regimen. Then it was a phase 2 study. It was a dose finding study here. The primary endpoint was safety. Secondary endpoints, again, the survival and the other outcomes. So next slide. What they found in this dose finding study was that 300 tremelimumab plus durva 1500 is excellent regimen combination to improve the survival. So the other regimens it did not work here. That dosages did not work. They were quite inferior to T300 plus D, so which showed the longest median OS in this study. So that's how they found in this study that this dose is appropriate, and then this dose was studied in a phase 3 trial, that is the Himalaya trial. So next study, next slide. Himalaya trial, the phase 3 multicentric study, tremelimumab with durvalumab as first-line therapy in unresectable HCCs. Next slide. Coming to the design of this study, we phase 3 trial, again, more than 18 years of age, patients unresectable HCC, BCLC B or C. They also included some of C, and child A was included, that's all, and no prior systemic therapy for HCC, well-preserved performance status patients, 4 randomization arms, STRIDE, Durva alone, sorafenib, and durva-tremi. The tremelimumab was 70 and 4 doses. This arm was discontinued once they came to the conclusion in the phase 2 study that this is the more appropriate regimen and dosage, that is tremi plus durva 300, and this arm was discontinued because it was shown that before the results in the preliminary analysis that this dose 1500 plus 300 is appropriate, and it improves the outcomes. So the outcomes here in this study were primary endpoint OS, secondary endpoints OS in the arm A versus arm D, response rates, and other outcomes. So next slide. Again, the treatment schema here, arm A was durva monotherapy every 3 weeks, and arm B was durva every 3 weeks, and tremelimumab 75 mg every for 4 doses. This arm was discontinued. Durva tremi, the STRIDE regimen, single priming dose of tremi 300 and sorafenib. Next. Coming to baseline characteristics, again, equally matched study here. All the characteristics were equally matched. We know here that the viral etiology was around 30% in all the arms. Non-viral was predominant 40%. Most of them are good performance status, 60% ECOG 0. BCLC-B was minority, BCLC-C was majority of the patients here. 80% of patients in all the arms were BCLC-C. And child Pew, majority, almost 99% were child A. The missing values for only just minority. Macrovascular invasion, around 25% of patients had macrovascular invasion. Extrahepatic spread, 50% of patients in all the arms. PDL1 positivity was seen in around 35% of patients, and most of them, around 35%, had more than 400 level of EFP. Next slide. What was the second subsequent line therapies after the progression on the durva tremi was here. Again, the targeted therapy was used in majority of the arms here. Durva also targeted therapy. We have got TKS in the second line. Again, the immunotherapy was used in minority of patients in those who had received immunotherapy in the first line, except in sorafenib, 17% of patients received immunotherapy in the second line. Next slide. So coming to OS, which was a primary endpoint here, it was significantly improved. There was overlap initially, but that's how the immunotherapy trials go. Then it started separating that nearly 5 months here, and there was a wider and wider gap between the curves as the treatment follow-up increased. So at the 18 months, we can see a good difference in the overall survival. 24 months, again, 8% improvement in the survival with STRIDE. And at the end of 3 years, it was around 10%. So this survival difference progressively increased as the time follow-up increased. So at the end of 3 years, it was around 10% difference in the survival. It was quite significant. Again, the hazard ratio of 0.78, p-value was significant, median 16 versus 13. So significant improvement in the overall survival with this regimen. So the highlight of this study is those who had responded had a maintain this response for a longer duration. So that is the highlight of this study. Next slide. Coming to the subgroup analysis here, again, it worked in all subgroups and especially in the viral etiology and the non-viral etiology. So HBV and non-viral, it worked very well. HCV, it did not work so well. Maybe the number of patients were less. That's why we did not see the difference here. And except that all of the other subgroups, there was a good improvement in the survival with the STRIDE regimen as compared to sorafenib. Next slide. Response rates again significantly improved here, 20% objective response rate as compared to 5% with sorafenib. Look at this median duration of response, 22 versus 18. So those who had got a good response, they maintained the response for a longer time. That's how this regimen improved the response rates and also the median duration of response. Next slide. Adverse events, you can see here in the sorafenib, the adverse events are more as compared to the STRIDE regimen. In fact, it is safely tolerable, not much side effects. Grade 3, 4, the adverse events were 25% as compared to 36% with sorafenib. And the immune-related adverse events were 12% as compared to 2.4 with sorafenib. And those requiring high-dose steroids were around 20% of patients. Next slide. What were the common adverse events seen? Rash was predominantly seen in STRIDE. And also diarrhea was more commoner in the sorafenib, we know that, and HFS was more common in the sorafenib. So rash, itching, diarrhea, followed by some thyroid abnormalities, and the other things are non-specific. So it's a safely tolerated regimen and not much side effects except for the skin abnormalities and diarrhea. Next. The one point we know that is because of the anti-VEGF component, the bleeding risk is more there. So varicose bleeding and the other bleeding risk is more. There's proteinuria and all those side effects, which are very less in this STRIDE regimen. So the treatment-related side event, the adverse events are very less in the STRIDE as compared to other regimens. The varicose hemorrhage is almost nil in the STRIDE regimen. Next. So the NCCN guidelines now tell us that the first line treatment of choice in advanced HCC is either atezo-bev or STRIDE regimen, that the tremi with durva. The other category 1 recommendations are durva alone. If you can't use tremelimumab, lenvatinib, sorafenib, and other immunotherapies or category 2B recommendations. The second line therapies again, Cabo and Rigora. So Nivo-IP is not yet in the first line recommendation according to NCCN. Next slide. So to conclude, we know we can tell that HCC is the topmost common cancer affecting Indians. The viral, the etiology is gradually shifting from viral to non-viral etiology, and NASH is the most common etiology now for HCC in India. And the immunotherapy combinations have shown the better anti-tumor activity than the TKIs alone. The atezo-bev till now it has been remained a standard of choice, but STRIDE is proving equally well now, equally better, and in some cases in which you have to avoid the atezo-bev like varicose hemorrhage, where the risk of varicose hemorrhage, and you can't use those who already undergone surgery, some other surgery, and the wound healing is a problem. There we can use the STRIDE regimen. It's not an alternative. It is going to be equally well. We don't know what risk factors to be seen in selecting the therapy, the STRIDE versus I am brave, and it has worked in all subgroups, including the non-viral etiology, and it is well tolerated. So with this, I conclude my talk, and I thank you all for your patient listening and participating in this activity. And thank you. Thank you.
Thank you, sir. For the next talk, I would like to invite Dr. Anand V. Kulkarni.
Are my slides visible?
Yes, sir.
Sorry, apologies for the delay. There was some internet connection. I lost it at last moment. So thank you, Arif. It was a great talk on IOs and the INCCN guidelines and in detail about the steroid regimens. I'll be talking about in brief about the systemic therapy for HCC. Basically, we have been very much interested in HCC, and we have been working and we have been having a great database of HCC patients as well. A huge database of more than 1,000 patients. In this talk, I'll be touching upon what is BCLC, what is Ginast's modification of BCLC. That is the one which we follow as hepatologists. We have been tuned to use BCLC itself, and for portal hypertension, we follow the Bhavana guidelines. So this has been ingrained to us. We also follow we read other guidelines, the ESMO guidelines, the NCCN guidelines, but somehow we are very much comfortable using the BCLC one because it is probably more liver oriented than cancer oriented. And I will also be discussing what is the aim in HCC, how to achieve that aim, what are the drugs, and what are the role of combination of these systemic therapy and local therapy, which you have heard now by previous speakers, Dr. Jignesh and Dr. Arif. So BCLC, basically this has classified into 5 stages, 0 to D, 0, A, B, C, and D. Systemic therapy has a role in BCLC-C. That is where the role of systemic therapy comes. The previous BCLC said that with patients in BCLC-C, despite the best evidence of the systemic therapy, the survival was hardly 10 months. In the latest modification, they changed and decreased it to survival to 2 years. It is because of the availability of good drugs, which have made a long-term survival dream come true for these patients with HCC. However, we don't not only use systemic therapy for BCLC, we also use them for patients with BCLCB. We also use them for BCLCA, provided they have a very high small tumor, with very small tumors may have a high alpha fetoproteins. In such situations, when we do local renal therapy, we tend to add them on some form of systemic therapy, usually lenvatinib in such situations. According to BCLC, the recommended drug of choice is first is atezolizumab or the combination of durva and tremi. If not feasible, sorafenib or lenvatinib or durva alone. This is what's been said in the previous speaker also. Second line drugs, if the patient has received sorafenib, then you may go ahead with regorafenib. If the patient is tolerating sorafenib and progressing, regorafenib is a good drug. Cabozantinib, even if the patient is not tolerating, you can also use cabozantinib. Ramucirumab, it actually failed in the initial trial in patients who had HCC. It had excellent efficacy in patients who had VEGF, alpha fetoprotein more than 400. That is when we use ramucirumab in such situations. Post-atezolizumab, bevacizumab, or post the use of durvalumab, probably and post-lenvatinib, probably the best drugs available are clinical trials where the patients may benefit the most. Other than that, usually don't use these drugs in second-line drugs. More often than not, if the patient does not respond to any form of immuno-oncological agents, we end up suggesting them TKIs, but we know that they usually don't respond to TKIs as well. Once they do not respond to IOs, there is a systematic review which has suggested that you may add IO, but response may not be that great. Third line drug as of now is cabazitaxel. I think this has been modified. This has been undergoing rigorous changes again and again within years. We have had multiple drugs which have come up. There are second line immuno-oncological agents which have come up. I saw a recent prescription from one of the major institutes on Nevo EP. Also, there have been multiple drugs used in recent years for this HCC. Following the success of atezolizumab, there have been robust increase in the studies on HCC. The difference between NRCL, BCLC and the BCLC. The difference between NRCL, BCLC and the BCLC is we have two stages in C and D stage. Stage C1 where there is portal invasion without any extrahepatic spread, and C2 where there is extrahepatic spread. In C1, the feasibility of systemic therapy is high. We can add, we usually add either TAIR or SPRT or resection if feasible, and then also add them on systemic therapy. Also, there is stage D, where we have subcategories to D1 and D2. If the patient, despite having advanced liver disease, the tumor is remitted to liver, we may also add them on. We may suggest them for transplant. That is one important modification of finasteride BCLC, which is not there in the primary team's BCLC recommendation. Stage D2 is where the patient has advanced poor performance status, tumor beyond transplant criteria of the select institute, then probably still best supportive care. So there are certain minor differences between staging of this A, B, C, D, and most important is offering the transplant to stage D, where the patient has poor liver function tests, but the tumor is related to liver and has alpha fetoprotein less than 400 or probably less than 1000, and probably decent performance status. However, systemic therapy again comes over here in BCLCC as well as BCLCB, where we have criteria, extended criteria, where we add them on locoregional therapy followed by addition of systemic therapy. With this background, the reason for this is that now we have changed our aim from just prolonging the survival of these patients to providing a cancer-free, drug-free, and good quality of life for these patients, apart from increasing their overall survival. But this is only possible with the recently available drugs. This was not possible with the first drug, which was available in 2008, 2007, with sorafenib. The SARC trial, which showed that the survival difference was hardly around 3 months. This was followed years later by lenvatinib, which had excellent survival benefit, overall survival of 13.6 months. And it was a non-inferiority trial. But what we see in our clinical practice, it has a really decently good performance data coming, good overall survival in clinical practice. The later on study which was approved was IMBRA 150 on atezolizumab versus sorafenib, which updated survival showed that 19.2 months for these patients. Then we had the Himalaya trial published in the GIM, evidence showing that durvalumab provides excellent overall survival of 16.4 months compared to 13.7 months in sorafenib. On second line agents, we have regorafenib, the resource trial, ramucirumab, that is REACH2 trial, where they had patients who had intolerant to sorafenib, but had progress and had also alpha-fetoprotein more than 400. In the REACH-1 study, they could not identify any beneficial patients. That is the reason they performed this REACH-2 study, where they had patients who had alpha-fetoprotein more than 400 who had benefited with this drug. Cabozantinib, again a second-line drug, can also be used as a third-line drug. Nivo-P probably will be approved as a first-line drug and pembrolizumab as a second-line drug. I have no much experience with the use of ipilimumab or pembrolizumab. Nivolumab alone I have used in a few cases, and as a quite safe drug, to be frank. It's a very safe drug, although the initial study did not have it lost the p-value by 0.01. It was 0.06 or 0.07. That's the reason it could not be approved for patients with HCC. Pembrolizumab has been rapidly used, but not used for any of these patients with HCC. Once they progress on immunotherapy, I usually end up starting them on TKIs. The liver already has a mild ascites or high bilirubin, I usually don't give them any medication once progress. For all these major clinical trials on HCC, the only inclusion criteria is BCLC B or C, CTP A, and good performance status, and patients who had unresectable HCC. And again, this should be again for first-line therapy, they should have not received any prior systemic therapy. I totally agree with these inclusion criteria. The problem with our practice, as Srinivas was already highlighted, that most of our patients present it when they have CTP-B or CTP-C. It's not so early. CTP-A, most of our patients don't come to us at that situation unless they are on surveillance, regular surveillance, and have been identified on regular surveillance. We usually get symptomatic HCC patients in advanced stage itself. How do the drugs work? There are multiple drugs, as I discussed before. There are IOs, the TKIs. The competition is between these IOs versus TKIs, or the combination of IO and IO versus IO plus TKI. But there have been no great success with the use of IO plus TKI. There have been some success with the use of IOs alone and also IOs plus IOs as well. The advantage of why lenvatinib scored over sorafenib was basically it had the additional action of FGFR4, where it has been shown to have better beneficial effects and probably much more efficacy than sorafenib. The only disadvantage with the use of lenvatinib was the hypertension, which we commonly see in these patients, although it is common with all the IO agents as well, but hypertension is the commonest adverse events what I notice in these patients, and palmoplantar dysarthria, that is a hand-foot mouth syndrome for this patient. On the immuno-oncological front, we have extensive evidence supporting the use of all the three drugs, PD-L1 inhibitor, that is atezolizumab, nivolumab, and durvalumab, which was anti-PD-L1. Anti-PD-1 is pembrolizumab, and anti-CTLA-4 is tremelimumab and ipilimumab. The combination of tremelimumab, a single dose of tremelimumab, followed by multiple doses of durvalumab, that is a STRIDE, has shown to be excellent efficacy and probably the first-line recommended drug in patients who have a high risk of varices or variceal bleeding. Usually end up starting on STRIDE. If the patient has no evidence of high-risk varices or high risk of variceal bleeding, we start them a combination of atezolizumab and bevacizumab. If this is not suitable for these patients, I recently saw a patient who was started in Nivo-EP and then the patient had variceal bleeding. So I'm not sure we should actually, we also had a patient who was started in STRIDE and had variceal bleeding. So I don't think any of these drugs per se cause variceal bleeding. It is probably the disease itself which is causing variceal bleeding, not the drugs which cause the variceal bleeding. I totally agree that bevacizumab, a VEGF inhibitor, may increase the risk of bleeding, but not portal. It does not lead to variceal rupture. It probably increases the portal pressure in patients who have portal vein thrombosis, and that then leads to variceal bleeding. That is what my hypothesis is. I'm not sure of this, but that's what I believe. We have also seen patients with lenvatinib having presenting with variceal bleeding when the patient has large tumor and portal vein thrombosis. Regorafenib and cabozantinib, no great experience, but regorafenib actually it's quite toxic. Most of our patients did not, whatever patients I started on them on, they did not tolerate well. Cabozantinib, well tolerated to 40 mg, not beyond that. They usually present with loss of taste and multiple oral ulcers and again hand rashes. There are advantages of each of these agents, that is IOs and TKIs. Obviously, TKIs are quite economical. They're easily available. They provide decent overall survival, not a great overall excellent survival. And there are no unusual adverse events. We don't need to have a great team to manage these adverse events. In fact, if you see for oncology, it's a nightmare for using IO. We have only one disease to use IO. We have multiple diseases where they use IO and they see a lot of adverse events with these IOs. The advantage of IOs is it can give us a complete response in up to 10 to 15% of patients. We can take them for transplant. It can act as a bridge for these patients. It can also act as a downstaging modality. And it also provides a good long-term survival. The disadvantage is that IO is yes, definitely it's not economical, not easily available. There are unusual adverse events you have to be well versed with, and it cannot be used in post-transplant patients. There is a risk of rejection for these patients. While TKS can be used in post-transplant patients, complete response is very, very rare in these patients, and I have not seen any patient undergoing transplant after receiving lenvatinib or any of these agents or being downstaged as such. They may have received as a bridging therapy, but not as a downstaging therapy. As adverse events, as I said, for IOs, we have immune-related adverse events. There is immune-related autoimmune hepatitis, bleeding, proteinuria, hypertension, which can occur with these drugs. For TKS, it is usually diarrhea, proteinuria, fatigue, nausea, vomiting, and hypertension. With one IOs, we also see that there is hoarseness of voice, weakness, and fatigue and fever, which commonly occurs for these patients. The reason why we use IOs is the good response, what I said before, and also Arif has already told that there is good long-term survival. This is the iEmbryo study which showed good long-term survival with this drug. There is a similar study from STRIDE which showed excellent overall long-term survival for these patients. It was probably the first study to provide a long-term report of long-term survival. 3-year survival rate of 30% versus 20% with those who received sorafenib. Objective response rate of 24% versus 7% with sorafenib. Complete response, again here, if you see, it's around 3.5 to 5% versus 0. And in partial response was 21% versus 6.7%. So if I'm not sure whether etiology makes any difference for any of these patients. It is all about the management of these patients. All these patients respond both either all the drugs, be it adazabeo, STRIDE, or TKI. I don't buy that etiology-based treatment actually matters in these patients. What it matters is the tumor burden and alpha-fetoprotein. Is transplant feasible after IOs? Yes, definitely. There was a strong data with nivolumab. We also have good data with atezolizumab and bevacizumab. There have been multiple case reports. These are some of the case reports which have been published. We have also published our downstaging reports in one of the journals of liver cancer, where we used atezolizumab as a downstaging modality. 10.4% were downstage out of 100 plus patients. We performed some liquid biopsy for these patients to identify those who may have high risk of recurrence. Patients who had low tumor mutational burden or ctDNA and microsatellite inhibition, they were taken up for transplant. One had undergone C-section, 5 underwent transplant. There was no recurrence at that time, but there was one recurrence we have seen in the recent year. After 1 year, a patient developed recurrence of hepatitis B, rejection, and then patient had treated with augmentation of the immunosuppression. One patient has developed a recurrence also after 1.5 years who underwent cadaveric transplant, and this patient is on lenvatinib as of now. At that time, there was no recurrence or rejection, but now we have seen one recurrence and one rejection. The problem with this drug is use of bevacizumab may impair wound healing for these patients. So we need some evidence to probably to help STRIDE as a better drug for these patients to downstage or to bridge them to transplant for these patients. There are multiple studies, Plenty trial, immunoaccessile trial, Vitality study, which was published in JHEP recently, all of them showing that IO can be used as a downstaging or also bridging modality as well for these patients with HCC to transplant. Bridging in India is not of great benefit. We need more of downstaging modality. Bridging probably in the LDLT settings is of no great benefit. Choosing your drug is based on this. If patient has advanced HCC, child PUG is suitable for IU. You can, and anti-VEGF suitable, that is patient who has high risk of bleeding or high proteinuria, they would not be considered for Atisbave. They would be taken up for durvalumab. If they are not suitable for IU at all because of the autoimmune diseases, lenvatinib is a better drug. Patients who have child PUG, poor performance status, or elderly, you may just add them on durva and wait and watch. Now, immunotherapy has become the standard of care for these patients at HCC. All the guidelines now recommend that the use of stride and atezolizumab should be the first line drugs for these patients. Timing of therapy. This is one important study which I felt is placed in ESMO Open. What they noted was in solid tumors patients who received immuno-oncological agents in the early morning hours around 12 to 4 p.m. They had better response because of the increased immunity during that period than those receiving in the evening hours. Some data on combination of TACE and TKIs. There have been multiple studies, Tactics Launch and Tactics 2. All of them have shown that good response with the combination of TACE and lenvatinib. This has been discussed previously, but what we use is patients who undergo TACE and have high alpha-fetoprotein, I end up adding them lenvatinib on follow-up. Therapy plus atezolizumab, we have been using this TARE plus SPRT or SPRT plus IUs and has been decent result for this patient. There are multiple studies. These are the studies which are ongoing on combination of IUs and locorenal therapy. Emerald Leap, I think Leap is already out. Emerald 3 Stride plus lenvatinib plus TACE and Talent, TACE and Impact. These are the ones which are already on patients with HCC and unresectable HCC or combination of IO and LRT. This is one good slide which I usually use. Definition of clinical response, that is achievement of complete response for fulfilling of these two, or normalization of all the three markers. Although we don't use AFPL3, but it's a good clinical criteria to identify patients who responded to therapy and when to switch off the drugs. That is the commonest question we usually are asked. This is one good study. I mean, editorial by Kudo, where he said that achievement of complete response by superselective TACE, continuous normalization for all the three markers for 12 to 24 weeks, and complete disappearance of intranodular arterial flow. Then that is when you can patients can be switched off from the drug. SBRT plus IO, again decent data with nivolumab has shown good response. But the combination of IO plus TKI has not been as any great support of evidence till now. What we usually do for BCLCC, we usually end up adding them a LRT plus systemic therapy for this patient. If they have extrahepatic mets and if they are feasible for ablation, we end up adding one ablation modality for those patients. Identifying ideal candidate for any kind of systemic therapy, good performance status, BCLC B or C, BCLC child for A, or up to 8 only if the bilirubin is less than 3 milligrams per deciliter. Age, etiology, and tumor burden are unrelated. For ICS, rule out autoimmune diseases. For atezolizumab, evaluate for varices, add them on beta blockers and statins. For ramucirumab, if the alpha-fetoprotein is 400 nanograms per ml and is not responding to first-line therapy, the patient can be added on ramucirumab. Thank you.
Thank you, sir. For the next talk, I would like to invite Dr. Shantanan Dinesh Shetty.
Hi, Vishal. Thanks. I'll share my slides. Can you see my slides, please?
Yes, sir.
Yeah. Right. Good evening, everyone. After an exhaustive talk of advanced HCC by Dr. Arif and Dr. Anand. So currently, I'll be dealing with the questions in the early HCC. Yeah. So how can we define as clinical so can you hear me? I think there is some technical problem. I think it's been gone.
Yes, yes.
Shantan, if you cannot, it's better to switch off your video if your internet is not stable.
Okay. Yeah.
Mm.
Yeah. Yeah. So clinical characteristics when associated with early HCC, so it shows as in form of low tumor burden. Patients with early HCC have a low tumor burden, preserved liver function in the early stages of liver disease, BCLC. So it's a preserved liver function or a good performance status. So this is a BCLC classification, which shows that the management of early HCC includes if the patient has some potential candidate for liver transplantation, you can go for liver transplantation in case of elevated liver pressures or elevated portal pressures. But if there is no not a candidate for liver transplant, you can go for ablation or resection. So what are the factors affecting the treatment decisions for patient with early HCC? It could be a tumor burden, which specifically includes the tumor size, the microvascular invasion, surgical with wider resection margins, post-adjuvant intervention or active surveillance. Macroscopic portal vein thrombosis is not eligible for any patient with transplant or surgery. The liver factors include the Child-Pugh score and the Albay score. The patient factors include the ECOG performance status 1, the liver function, good liver function, no evidence of comorbidities, management of any active hepatitis B has been taken care of, and no evidence of any chronic alcoholism. The oncological factors include the low BCLC stage and the low AFP levels. So these are the good factors which affect the treatment decision patient with early HCC. So the surgical resection or a partial hepatectomy can be a curative treatment for localized HCC. However, many patients may not be eligible due to tumor extent or due to the increased portal pressures or because of the advanced liver disease. So in non-cirrhotic patients, surgical resection is a treatment of choice with very early stage or early stage, and with a single nodule, even if it is less than more than 5 centimeters. Even the current EASL or ACLD guidelines recommend surgical resection only in patients with BCLC-A with preserved liver functions. And the presence of portal hypertension itself is considered as a key contraindication for surgery. Major resections are feasible for those and the risk of complications are low. So when you're dealing with surgical resection, the procedures, they require careful consideration of early HCC tumor biology. So biology is important. The tumor burden is important. Future liver remnant is important. Underlying liver function and portal hypertension. All must be considered before a surgical resection is attempted. If the tumor burden itself is not while tumor burden itself is not an indicator predictor of HCC recurrence following surgery, but the increasing tumor size is associated with higher incidence of microvascular invasion and distant metastasis. Hence, the tumor burden should be taken care of. Next is a free liver remnant. So free liver remnant should be significant, at least of 40% in non-cirrhotic patient. The liver remnants of 40% should be required. Liver function, the liver function patient should have good liver function before attempting any surgical resection and no evidence of portal hypertension such as HVPG less than 10. Patients with HVPG more than 10 or patients with advanced liver disease, transplantation is a potential curative option even with early HCC who are not surgically resectable. So patients with less than 5 centimeter but advanced liver disease, second patient with poor liver function, low free liver remnant, all these patients are should be subjected to transplantation even with early HCC. So when we consider if the patient who has significant portal hypertension features, but the patient can be downstage, or it should be TACE can be used as a bridge to transplant or as downstaging for treatment with early HCC, who are ineligible for transplant, resection, or ablation in the first instance. So who are not eligible for ablation, resection, or transplant, patient can be considered for TACE, successful downstaging, and then patient can be going for transplant. So coming to the pre-transplant immunotherapy, which is a neoadjuvant therapy sort of picture, when pre-transplant immunotherapy, currently it's of great interest as a modality for downstaging tumor burden, and it's currently under investigation. There are various trials which have been undergoing. The clinical trials, they investigated the use of immunotherapy as a bridging treatment before HCC transplantation and provides information needed to optimize the patient outcomes. So the largest series up to date was conducted by Mount Sinai Medical Center, where 9 patients with HCC were successfully transplanted after receiving nivolumab as bridging therapy. But however, even from our center, we have published the data which is initially shown by Dr. Anand regarding the downstaging post-IO therapy. There's also a plenty trial which showed that the pembrolizumab with neoadjuvant lenvatinib in a treatment of HCC prior to liver transplant. However, the preliminary data that early results are still promising, final data yet to be shown. So when we see for the what are the other ablative methods which can be used are the ablation. So you have a radiofrequency ablation, microwave ablation, and you have even the thermal cryoablation. Already the locoregional part has been dealt with Dr. Jignesh. So currently coming to the these are all the locoregional parts where the RFA, microwave ablation, and the cryoablation parts, which can be where the early HCC can be dealt with. So now coming to the even after patients receiving surgery or ablation with curative intent, up to 50% of people with early HCC experience disease recurrence even after ablation therapies. Within 2 years, some patients gradually develop recurrence or a new lesion which are there, and up to 80% within the 5 years. So risk of recurrence persists even after 5 recurrence-free years post-treatment with curative therapies, such as the ablative therapies. Therefore, it is pivotal to identify the high-risk patients for recurrence. High-risk characteristics based on tumor size or number, patients having poorly differentiated HCC, patient having cirrhosis, increased AFP elevations, and microvascular invasion, or presence of any satellite lesions. All these mark the high-risk factors for recurrence post any locoregional therapies. So the recurrence pattern after early HCC treatment are diverse, including intrahepatic metastasis or metastasis independent of the primary neoplasm. It could be a nearly early recurrence where post ablation therapy, it could be at the edge of the ablative therapy, or it could be a new lesion which forms. So patients at high risk of early recurrence are candidates for close surveillance, and potentially they are the candidates for adjuvant therapy, and which has not yet been standardized. So monitoring patients post-treatment is imperative, as HCC has a recurrence rate of up to 80% in 5 years. These are shown by various studies, the various retrospective multi-center studies, which show that the HCC has a recurrence of almost up to 80% at 5 years, even after the ablative therapies. So the treatment of HCC recurrence post-resection is multimodal and should be discussed in MDT whether the initiation of any adjuvant or neo-adjuvant therapies. So how can we manage the recurrent HCC? First, identify the high-risk patients. You have the option of combination treatment patients with recurrent HCCs, and more data is yet to be out based upon the prediction models of outcomes following treatment options for recurrent HCCs. So the main risk factors for recurrence after resection in most studies include the tumor size, the presence of satellite lesions, the vascular invasion, and the tumor differentiation. So there are various studies starting from 1996 to 2016 and ongoing still trials are going on that effective adjuvant treatment for patients with HCC even now remains a key unmet need. Most adjuvant trials up to date have failed, including the STORM trial, which included the sorafenib, which evaluated sorafenib versus placebo as adjuvant therapy after surgical resection or local ablation in HCC. Only the IMbrave 050, which included the atezolizumab and bevacizumab, had showed some positive results as an adjuvant treatment in terms of recurrence. So from the current ongoing trials are the Jupiter 4, the Keynote, Checkmate, the IMBrave 050, which has been published last year, which showed that the addition of Atibeva showed a significant decrease in the recurrence when compared to patients receiving not receiving any therapy. So the prevention of recurrence via adjuvant treatments is an important unmet need in patients with HCCs. So this is the STORM trial, which is a phase 3 trial which evaluated sorafenib versus placebo as adjuvant therapy after surgical resection or local ablation in HCC. So this sorafenib did not show any significant treatment effect on overall survival or the possible explanation because the patients could not tolerate sorafenib, and if there are many patients who had discontinued up to 1 year, the almost 1 year discontinuation rates were almost 50% for sorafenib. So that STORM trial did not show any significant benefit, although the dosage was not sufficient enough and the patient could not tolerate it. So there are currently many ongoing adjuvant trials for ICI monotherapy or a combination therapy. So this is the IMBrave 050, which is an open label phase 3 trial, including Atibeva versus active surveillance. The recurrence-free survival was the primary endpoint and it showed a good benefit. The combination of atezolizumab and bevacizumab showed a significant recurrence-free survival compared to an active surveillance. There are other studies which have been going on, which is the Emerald 2, which is also Durva plus bevacizumab versus placebo. And currently at present, estimated study completion in 2027 is still the results have yet to be out. So the one more study is the NIVOLVE study. So NIVOLVE was designed to assess the efficacy and safety of nivolumab as an adjuvant therapy in patients with HCC after surgical resection or radiofrequency ablation. It's a phase 2 prospective multicenter single-arm trial. Almost 11 sites are involved. And after the patients which showed a complete response, almost by RFA or the surgical resection, almost 55 patients were taken. Primary endpoint was 1 year's recurrence-free survival, and the key second point was recurrence-free survival. Currently at present, the 1 year recurrence-free survival was 76% in the group which received the nivolumab, and no new safety signals were observed. The adjuvant IO combination in early HCC reduced the risk of disease recurrence, which is shown by the IMBrave 050, which is a phase 3 trial, which included adjuvant atezolizumab and bevacizumab versus active surveillance, and this showed us positive results. One more trial, which is in the phase 2, which is immunomab, which is a pembrolizumab plus local ablation, addition of pembrolizumab plus in the addition of local ablation. They did not meet the primary endpoint. Following ongoing follow-up, median survival was not reached. However, there is evidence for the efficacy of peri-interventional treatment with pembrolizumab combined with local ablative therapy. So this is the IMBrave 050. After 18 months, the distance have come down between the curves, making it difficult to conclude the real effect of AT plus Beva versus active surveillance. Initial few months, there is a significant difference in the recurrence-free survival. But after 1.5 years to 2 years, the difference in between the two recurrence-free survivals have come down. So longer follow-up is needed to understand whether the atezolizumab bevacizumab is delaying the recurrence or impacting the long-term biology of the disease. Another trial is the Emerald 2 trial. So Emerald 2 trial, it investigated the durvalumab plus bevacizumab in HCC at high risk of recurrence after curative resection or ablation. It's a phase 3 randomized double-blind placebo-controlled trial. So one arm received durva plus bevacizumab, second arm received durvalumab plus bevacizumab, and the third arm is a placebo. So arm B had a placebo in place of bevacizumab. So it was 2 drugs, 1 drug, and no drug. Results are yet to out. So currently there is no standard protocol for the application of neoadjuvant therapy in patients with HCC. So early introduction of systemic therapies may potentially decrease the risk of recurrence.
Sorry for interruption, sir. Kindly conclude your.
Hello.
Sorry for interruption, sir. Kindly conclude your talk.
Sorry.
Sir, kindly conclude your talk in 2 minutes.
Okay. So IO has been successful in advanced HCC, neoadjuvant immunotherapy in other cancer types. Neoadjuvant immunotherapy can stimulate a broader range of T cells. However, in the rationale of neoadjuvant immunotherapy in resectable HCC, so identify resistant tumors, neoadjuvant therapy as conversion therapy, and addition of locoregional to neoadjuvant immunotherapy is currently ongoing trials, but only the post-adjuvant therapy with ATI and BEVA showed significant better results in the early stages, but at the later stages, the duration, the recurrence-free survival has come down. So summarizing the talk, there is high recurrence up to almost 80% post-treatment with curative intent treatment modalities. There is no peri-standard perioperative treatment protocol for early HCC currently. Several trials are ongoing in this highly unmet need, and results from IMBRAVE 050 trial looks promising to reduce the recurrence when immunotherapy is introduced in the early settings of HCC. Thank you.
Thank you, sir. For the next talk, I would like to invite Dr. Sumanna Kolar Ramachandran. Dr. Sumanna.
Can you see my slides? Can you see my slides
No, ma'am.
now? Can you see it right now?
No, ma'am.
Share screen.
Technical team, please help.
Can you see it now?
Yes, ma'am. Ma'am, make it full screen.
Okay. You're not able to see my video, right?
Yes, ma'am.
I'm sorry, just a second here. Is it okay if I just go on like that without video? Hello? Hello, can you hear me?
Yes, ma'am.
Is it okay if I just put off my video? Because I think my internet is not great.
Okay, ma'am.
Okay, I'll try to do it. It's blinking, so better off it. Okay, I'll go with my topic. So I'm going to discuss surgical management of HCC and the challenges that we face in our real world. So I think most of it has been discussed. I will not go in length, but we know that it is a leading cause of cancer death, and HCC ranks as the sixth most common cancer worldwide. If you look at the Indian specific insights, it's a growing concern, and HCC is the second most common primary cancer in India. And a high burden of hepatitis B is what we see with the newer inclusion, that is the NASH. Late diagnosis, most cases are diagnosed at advanced stages, limiting the curative treating options. That is the main concern that we see. Approximately about 10 to 20 cases per 100,000 population annually is what we are looking at. The treatments for HCC have evolved in a great deal, which we have already seen and people have talked about now in the last 4 decades. But still, surgical treatment remains the mainstay of curative treatment option. And the surgical treatment can be either resection or liver transplantation. So if you look at the BCLC staging, we would like to see most of our patients, or the surgery is mainly for patients in the early stage or intermediate stage. But unfortunately, we see most of the patients, we see them at a later stage, mostly in the intermediate or the advanced stage. So now then the combination therapies or either the downstaging them, all these things come into play. So in the clinical practice, most of the patients come to us in the intermediate or advanced stages. There's a lack of robust DDLT program in our country, and there is generally no living donor in the family because of more nuclear families in the present world. And there is a financial concern as our country's healthcare is self-paying. So if you look at the two options that we have, and if you start comparing them, which one to give to the patient. So then we have this meta-analysis which looked at about 18,420 patients, and here 35 studies were included, and the liver resection had a poorer overall survival when compared to liver transplant in patients who have multiple lesions, though they were within the Milan criteria. But but there was no difference between both of these when there was only a single lesion and within Milan criteria. So in summary, mortality was nearly 50% higher among patients with HCC treated with liver resection versus LT. However, this is what they concluded. However, survival was similar between patients with uninodular disease who underwent resection and LT. Similarly, after resection and LT was also similar in Asia, where LDLT predominates, but not in North America or Europe. So this data, greater efforts are required to improve adherence to surveillance for HCC recurrence, especially. One second. So how to select these patients? Do we resect or do we transplant? So the things that we need to consider in deciding between liver transplant or resection is that we should look at multiple things. That is availability of organ for LT, liver function, basically, that whether there is, what is the functional status of the liver, is there cirrhosis, or long-term outcomes, where you look at the recurrence, if there is a recurrence rate which is going to be high despite resection, especially when you consider viral etiology, hepatitis B and C, and off late, we even think that the long-term outcomes of recurrence is higher in patients with NAFLD. Mostly identified as a screening process, we also look at liver function and tumor related, that is AFP and PIVCA, which is already talked about. We look at we do a triphasic CT or MRI. And portal hypertension. This is one of the major considerations which will help us to decide whether this patient has to undergo resections or liver transplantation. So we look at to look at portal hypertension, there are multiple ways. We look at the MELD score and the CTP score, and thrombocytopenia. Is there ascites? Do they have multiple episodes of variceal bleeding? HVPG, like Dr. Shantan has already mentioned, the recommendation is that less than 10 mm of Hg is when you can consider resection, but not in all the patients who have similar findings. But who have like if their HVPG is less, but still there is a severe thrombocytopenia, HVPG may still be around 7-8, but still they have ascites. That's when we will put them to a transplant list. So 3 major areas for considering in liver resection, like I already mentioned, one is the oncological appropriateness. So if you are looking at a patient with HCC and so you are trying to give them a surgical option, so you have to look at whether if the resection of the tumor is going to give them an R0 resection. So that is the oncological appropriateness. Then you look at the host condition, that is the general health of the patient, how fit they are, their performance status, all these are included. Then in technical resectability, so the location of the tumor is what we look at. How many numbers and what is the size? Is there a vascular inflow or outflow? And what is the biliary drainage? Then the most important thing in the technical resectability and whether the patient is going to withstand surgery is the future remnant liver volume, and also the quality of the future remnant liver. When you considering for the technical resectability of HCC patients with cirrhosis, if there is cirrhosis, you look at extent of the disease, whether it's so we look at whether there is only whether it's contained within the liver or there is extrahepatic disease. We look at whether there is a portal vein involvement, whether sometimes they have this portal thrombosis, which could be just a bland thrombus and not a portal venous tumor thrombus. Then like I already said, remnant liver volume is what we look at. Supposing it is a non-cirrhotic patient and the liver is in perfect quality, then up to 30% is good enough for us. But if we think that there is a fatty infiltration, then we look at the other parameters like HVPG, which you look at the liver function test, and then decide on the remnant volumes. And in some centers, people are also looking at ICG retention, which is not generally practiced on a routine basis. So is portal hypertension a contraindication for resection? So overall this is a graph showing the overall survival curve of the whole study population of 241 patients who underwent liver resection for HCC with and without portal hypertension. So there is a difference, say statistically significant difference between the two. So oncological appropriateness, presence of a PVTT in HCC is often associated with poor prognosis. The tumors are aggressive in nature, with large tumors and multifocality often respond poorly. However, selected patients with PVTT, that is VP1 and 2 and 3, are able to enjoy the survival benefit ranging from 54% to 25% at 1 year after surgical resection. Patients with hepatic vein tumor thrombus in HCC is often associated with poor prognosis. The tumors are aggressive in nature with large tumors and like I already mentioned. This is the next slide, sorry. So when patients with hepatic venous tumor thrombosis in large series of HCC, they looked at it. And again, these patients who had surgical resection had better survival in this group of patients who underwent R0 resection for HCC, even with hepatic venous thrombosis. Then there's giant HCC. There's a large tumor which is loculated in one or two segments where we can go ahead and do a right or left hepatectomy. The morbidity is, again, this is a controversial issue. The morbidity is about 25 to 50%, where we need to have a extended hepatectomies, and the mortality ranges up to 8% in these patients. So patients, the patients who have significant portal hypertension. So this is a study published by Azole, and they looked at the liver resections for HCC in patients with actually clinically significant portal hypertension. So they saw that the mortality was up to 6% with severe morbidity, which is about 27%. But generally, the morbidity is not too high. You expect a morbidity of about less than 5% in patients who do not have severe portal hypertension. Then 35% of them were actually decompensated post surgery, and 5-year overall survival was 55%, and 5 years recurrence-free survival was just 43%. So final considerations for liver resection. Resection is indicated in uninodular lesions with Child's A or B and with an HVPG, that is the portal, it's a hepatic venous portal gradient is what we look at to look at the portal hypertension, which is HVPG of less than 10, and a good remnant volume and a good performance status is what we look at. Can also do for advanced HCC with vascular invasion after accepting the morbidity and mortality if it is going to be offering them a better survival than other modalities. So liver transplant for HCC, the Milan criteria provided the opportunity for HCC patients to undergo LT with favorable outcomes. The paradigm for the patient selection for LT appears to be shifting from morphologic criteria, combining of biologic, histologic, and morphologic criteria, and to be establishing as a modality predicting post-transplant recurrence and outcomes. In the 80s, many transplants were done for HCC. That is when, in the early 80s, the transplant was mainly indicated for patients with cancers, and that's where they had a they had a lot of recurrence in these patients. Then came the Mazzafero or the Milan criteria based on a prospective study in 1996. So patients with early disease, that is patient who belong to the initial days, the transplant was indicated only in patients who were within the Milan criteria. Then later on came the UCSF criteria. That is, initially it was less than 3 tumors, not more, not the maximum size of the tumor was not more than 5 centimeters. Then we have many after the Milan criteria, that came the UCSF criteria, where the single tumor was less than 6.5 centimeters, more than 2 to 3 lesions not exceeding 4.5, with a total tumor diameter of less than 8 centimeters, no vascular invasion and or extrahepatic spread. There were various extended criteria for HCC, for HCC for transplantation. So, which included the Pittsburgh criteria, and from the east there is this Hangzhou criteria, and upon up to 7 criteria and Toronto criterias. So there were many criteria which started getting included, and if you look at they also started including AFP, and recently we have included PIFCA, and they started using in Japan. They had this multicentric trial where they looked at the nodule size being less than 5 centimeters diameter, and every center started having their own, most, I won't say every center, many centers which published their data started having AFP as a criteria along with the size of the tumor without any extra hepatic disease. Some people used AFP criteria as AFP as less than 200. Some people used it up to 1,000, and then later on, PIVCA started being included in the criteria, which were the extended criteria for liver transplantation. So, like I said, most of these patients who come in our clinical practice, they come to us in a late stage. That is, where they already have HCC along with portal vein tumor thrombosis, or they have a very giant HCC. There can be the tumor thrombosis can be of VP1, VP2, or VP3, or sometimes we see the tumor extending up to the SMV, and we have patients with hepatic venous tumor thrombosis. So this is a wide spectrum of patients that we actually see, though we want to see these patients in a very early stage. So, like I said, today we are not just using size as the criteria. So apart from the morphological criteria, we have the AFP, PIVCA. We also have the PET avidity, FDG avidity, and we look at the NLR, PR, and histology and other biomarkers. The novel biomarkers like liquid biopsy are still under research. So what we do when we get these patients with portal vein tumor thrombosis conventionally is that, earlier it was actually a contraindication, but now with downstaging, even this group can have a long-term survival of resection or after resection or LT. So we maintain the double equipoise concept, where we give a maximum benefit to the patient with a minimum donor risk. That is what we look at. And downstaging recommended in LDLT, even with adverse biological factors. Minimal recipient survival is contentious, and transplant benefit is a better metric. So there are many studies which have, especially from the eastern part of the world, which have looked at these extended or locally advanced tumors. Downstaging of HCC, they were case series or case reports, and we have one from our own country where they have looked at the Medanta the group has looked at and they have published their experience with LDLT in patients with HCC and portal vein tumor thrombosis post downstaging, and they said that there was more than 50% survival in patients at 5 years in patients who were downstaged either by TACE, SBRT, or TACE followed by lenvatinib. So this is the group of patients that we are looking at, where they may not get a 50%, more than 50% survival at 5 years if they undergo only a single modality of treatment. So these are group of patients, or a selected group of patients who have a transplant benefit, and the gain is offered by LT in comparison to the best alternative therapy. So if you look at the BCLC staging, this is a set of group which belongs to the advanced stage, and the best survival is predicted in these patients with isolated immunotherapy is 2 years. But when you do these patients after downstaging with immunotherapy, which has already been published, and I think Dr. Anand has already spoken about, we are looking at a recurrence-free survival, or 50% survival at the end of 5 years. So the transplant benefit, if you don't give them transplant, most of the patients die. 8 centimeters or 7 with no PVTT. If there is no, again, transplant, if you transplant these patients, like with downstaging, either with TARE or SBRT, or TACE or SBRT, so these are patients who can be offered a benefit of transplant. So there is a clear case report, successful transplantation after achieving complete clinical remission in advanced HCC with immunotherapy. And our own Dr. Anand Kulkarni has published this data on, we have, I think, 6 cases where 4 had underwent living donor liver transplant.
Sorry, ma'am, for interruption. Kindly conclude your talk.
Okay. So this basically, we are looking at, in the present world, we are looking at a multidisciplinary approach for an individual. We have, with the evidence that we have to customize these, individualize these patient care or the treatment options for these kind of patients who come to us with a multidisciplinary approach, and give them the best for each individual. Thank you.
Thank you, ma'am. For the next talk, I would like Dr. Anand Kulkarni.
I think we have crossed the time. I think I'll just quickly run through some interesting cases which I made. If somebody is active online, they can chip in and give us some insights. So this is one of the case. We had 3-4 cases, but I am presenting 1 or 2. This 54-year-old male was admitted to AIG hospital with complaints of pain abdomen, low-grade fever, and pedal edema. On evaluation, he was found to have HCV-related cirrhosis. He was known diabetic. On endoscopy, there was no great large varices. They had only issues with prominent veins. There is some amount of portal hypertensive gastropathy. And on blood testing, he was in Child-Pugh class B. His score was around 7B. And he had a large tumor of size around 12 by 8 centimeters. He was symptomatic, definitely, but was completely ambulatory. His performance status of ECOG performance status was 1. So based on the BCLC, he was in child BCLC C. The reason was there was some mild intraportal vein invasions also, which is not written over here. There was the right portal vein branch involvement. So this patient had come to us, BCLC C, Child-Pugh B, 7B, decent performance status, HCV-related cirrhosis, had taken treatment around 3 years back and completed DAS. Now he is known to have diabetes mellitus also. We did a PET scan to identify the lesions along with any extrahepatic mets. There showed that he had active tuberculosis as well in the lungs. I had prior history of tuberculosis, but that had completely cured. This was around 15-20 years back. And now again, he had active tuberculosis, a cavitator lesion. We also evaluated him completely thoroughly. He underwent a bronchoscopy that was gene expert positive. There was no resistance to any drugs. What to do in such patients was our dilemma. This is one interesting patient which I had. It took almost a week to understand whether he has active TB or not. I'm just shortened it to a greater extent because of the time. Basically, a patient with tuberculosis, active tuberculosis, and HCC. Anybody is here can answer this question. To start immunotherapy with ATT, to start ATT and wait, or start only IUs, or probably you think it is because it may be false positive being an expert, although I'm not very sure of that, and start ATT plus TKIs. These are four options which we are thinking about these patients.
How was his
So
performance status?
his performance status is good, madam. He's had good performance status, performance status 1.
So you could go for immunotherapy with ATTs. Could we do that?
That's an interesting point. We actually thought of that. So there are certain case reports and systematic reviews which has reported that tuberculosis infection following ICIs will be active reactivation of TB will be there. So this patient, we were very skeptical of starting on IOs because of the high risk of tuberculosis. There are multiple studies on that. The reason being, they say, I think there is some mistake in this slide. This is a good figure over there, where when you use IO agents, the latent tuberculosis, even if it is there, even if the patient doesn't have active tuberculosis, the latent tuberculosis may get reactivated because of the activation of T cells. Uncontrolled activation of T cells leads to release of the granulomas which are already existing in such patients and lead to activation of TB. This patient already had active tuberculosis, so he was not a candidate for IO agent. We
Okay.
started him on ATT initially because there are some evidence of the diabetic retinopathy. We did not give him on ethambutol. He had good amount of MTB in his gene expert. We started him on ATT post-consumption. Since LFT was okay, I had started him on aggressive, all the isoniazid, rifampicin, levoflox, and ethambutol. But child B, we were aware of that. But since the patient had advanced TB and HCC, we wanted to treat him aggressively. He developed hyponatremia. He had worsening of liver parameters. Since there was no other option left, we also started him on lenvatinib. We removed all the isoniazid, rifampicin. We started him on levoflox and ethambutol and lenvatinib. But again, he tolerated well for almost 2.5 to 3 months. Then he developed drug-induced liver injury and he died due to liver failure. This is the basic gist, but this is one untouched area. When I saw the literature, there was no much, no much treatment management of these patients is unknown, and everybody has recommended that patient in endemic areas you have to screen for these patients for tuberculosis. It was one interesting point what I learned in the recent times. To screen for all patients, we screen them in general, but not particularly for tuberculosis. But when this patient was picked up on PET scan, if we had not done a PET scan, probably we could have missed it. Because current guidelines don't recommend doing PET scan for these patients.
Especially
So,
sometimes when the PET CT shows some small nodules which they say that, or they report it as infective. I think that's where we actually seriously have to look at TB, I think.
Yes, madam. Yes, and that's what we had. No great idea. We had seen some reactivation of tuberculosis post transplant and all those things, but never saw a patient with IO and tubercular activation. Some of my colleagues have had this experience in PGI, but I had not seen any reactivation of tuberculosis. I think Shantan also had one patient. I don't remember. So this is the learning point what we thought was first to screen all for patients for the HCC treatment. We just screen for tuberculosis, and management of IO in such patients still remains an enigma. Till that time, TKI remains the drug of choice. There is a systematic review and meta-analysis which has compared the incidence of TB in patients receiving IOs versus lenvatinib, and they have reported that the risk of TB reactivation in such patients is 0% with TKIs compared to use of IOs, where it is 16 to 25% is the reported incidence of TB reactivation, even if the patient does not have active tuberculosis at the time of diagnosis of HCC. The second case which I wanted to highlight is something which is interesting. This was a elderly male with high BM of 29.5, diagnosed mass LD with HPV cirrhosis. His LFTs were pretty okay. His alpha fetoprotein was pretty high, 365, and TUCA was very high. There was no varices. He had large tumor with portal vein thrombosis, again child per class A and BCLC-C. So in such patients, question always arises, this patient has high tumor burden, has high alpha fetoprotein, high alpha TUCA levels. Should we treat these patients at all? Is our question whether will we be able to bridge or to downstage them for transplant or give some a good survival benefit? Was our question. This patient represented us almost around 10 to 12 months back. That is when we had started doing some research on this aspect to identify some predictors of IO therapy. There have been multiple studies. When we analyzed our own data, we couldn't find that alpha-fetoprotein, PIVKA, extrahepatic meds to be predictive of response to IO agents. So we wanted some blood-based markers. So we started using this PD-L1 expression in the blood. We took some blood samples. We assessed and recorded the lymphocytes and performed the CTC assessment in these patients. This patient had PD-L1 expression of around 104. It was pretty good. In our limited experience with this around patients of around 25, patients who have less than 20 or 30, they usually don't respond to IO agents. And we have very high amounts, they respond to such drugs. So we started him on atezolizumab. Following 6 doses, he had decrease in alpha-fetoprotein. He had decrease in PIVKA levels. The PET scan showed a partial response. He's still doing okay and continuing his immuno-oncological agents. And when we did his CTCs on follow-up, it had decreased by 30 to 40% on follow-up. So learning point here for a case-based discussion is basically there is some role. Japanese have some studies. That there are 1 or 2 studies from Japan showing that blood-based PD-L1 expression can be used, although there's no robust data. The data is conflicting. Some say there is no much use. Some say it is useful. Or there is further research required in this area, etc. We already crossed our time of discussion today. Any questions or anything? Everyone will be happy to take. Vishal, any questions or anything? Next time we'll have more case-based discussions where everyone will have active participation. I think everybody has left the Zoom call. How is the Chennai meeting, madam?
It's going. It is good.
Good.
It got little delayed. But it's good. The topics, everything is good. The GBM meeting went on, so I got delayed there.
Thank you, AstraZeneca, for sponsoring the
Thank you.
event. Thank you so much.
Thank you.
Good night.
Okay. Good night.
Night.
Thank you, sir. Thank you. Thank you, everyone.